I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com.
The most important part, and if you read the papers from the group in Seattle, they're trying to take the nerves and strip the nerves off the artery. It's more than just plucking a string. You have to what they call de-innervate the artery so that the pain goes away. Problem is, that's a surgical procedure and you can develop scar tissue and it can come back. So there's no guarantees.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos syndromes, dedicated to helping you navigate connective tissue disorders and live your best life. Today's guest joins us to share expertise for those living with EDS and HSD. Our conversation is unscripted and their views are their own, not those of me or the Bendy Bodies team. I am so excited to chat with vascular surgeon Dr. Robert Hacker today. We've talked a little bit in the past about compression syndromes like MALS, median arcuate ligament syndrome, May-Thurner Syndrome, pelvic venous congestion, and Nutcracker Syndrome. But today we will be getting the perspective of a vascular surgeon. So I'm really excited to have this conversation. Dr. Robert Hacker is a double board-certified general and vascular surgeon based in St. Louis, Missouri. He founded his private practice in 2023 to broaden access to advanced vascular care. His work spans complex arterial and venous conditions and has expanded to include pelvic venous disease, MALS, Nutcracker Syndrome, and May-Thurner Syndrome. Dr. Hacker frequently treats patients with EDS, POTS, mast cell activation, and related disorders. He is known for his individualized approach, integrating advanced imaging and minimally invasive interventions to help patients improve function and quality of life. I'm so excited to have this conversation because people so often suffer from these conditions, yet struggle to get properly diagnosed and treated. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Although we discuss healthcare topics, nothing on Bendy Bodies is personalized medical advice. Always consult a qualified healthcare provider for your own personal care. Stick around until the very end so you don't miss any of our special hypermobility hacks. Due to the highly visual and complex nature of these topics, I would strongly recommend that you check out the YouTube video if you possibly can. Here we go. I am so excited to be here with Dr. Hacker, a vascular surgeon who does lots and lots of work with patients with EDS, HSD, POTS, MCAS, etc., vascular compressions. It's so great to have you here. How are you doing today?
Oh, I'm very well, and I'm excited and honored to be on the show. So thank you for the invitation.
Of course, of course. I'm super curious to know how you got involved in EDS in the first place.
So this is all basically an accident or luck, if one would look at it this way. I used to be an academic surgeon for the first 9 years of my career, and wanted to leave the academic environment and start my own private practice so that we could deliver more affordable care, faster care, different types of care than you can offer in the hospital. And so part of that was converting from a very heavy arterial practice where you do some of the big stuff like gunshot wounds and rupturing blood vessels to the more bread and butter daily stuff like varicose veins, swollen legs, and wounds. So as the practice shifted, we started identifying a lot of patients, mostly women, who had swollen veins, varicose veins of various ages, 30s, 40s, 50s, 60s, 70s, 80s. And you start talking to them. And some of them had this diagnosis of May-Thurner Syndrome. Well, this is very well known in the vascular community, rarely seen in the hospitals, but very frequent in our clinic. So we started treating the May-Thurner syndromes. And it's interesting because they said, yeah, my leg feels better. And then you start to get the stories. Hey, did you know I've always felt this way since I was 20 years old, 30 years old? And now all my symptoms are gone. And some of these women were pelvic congestion syndrome patients. Some of them later on said, hey, I had Pott's disease. And they didn't really want to tell the doctor because of the scrutiny and the criticism that they get in the community. And we started getting 1, 2, 3 stories like this. And when we started getting 10, 12 stories, we said, there must be a correlation. And so we started really drilling down. And I had hired a new partner into the group, Dr. Shahadi, and she has a very strong background in research. And we started fracking our research. And we ended up publishing a paper and doing some statistical analysis on quality of life. And it turned out that the patients that we were treating were having very statistically significant quality of life improvements after 1 or 2 treatments. And now we're drilling down to what is really happening. And we've been working in the community with doctors who specialize in MCAS and POTS to see if we can find some corollaries. So it's all by luck.
Yes, same with me. This was not an intentional thing, really. Well, I guess it was intentional, but it wasn't part of my original plan. Let's say. So why do people who have connective tissue disorders, POTS, mast cell activation, why are they so prone to these conditions?
I think that is going to be the $1,000,000 question. And I think that as the research progresses in the scientific community, and the fact that now that we're seeing not just a medical component, but some kind of anatomic, correctable, or surgical component, I think what we're going to notice is that maybe we've been slightly misclassifying or not looking in all the corners. And I suspect in the end, it's going to end up in the nerve world, some kind of dysautonomia, some kind of way that the nerves are functioning that is yet to be described. I'm actually very fascinated where the next 10 years go with this.
Yeah, me too. Me too. So you talked about people dealing with things for many years, which of course is, the patients that I see. Absolutely. This is such a common thing. What symptoms do you find are most often overlooked or misattributed, but are things that you can actually address?
Yeah, so actually, I will tell you first off, 95 to 97% of our patients are women.
Mm.
We've treated close to 185 common iliac vein stents or May-Thurner Syndrome, and we're up in the 45 renal vein stents. Almost all of them are women, except for about 4 or 5 men. So I think a lot of the symptoms that the women are presenting with, the men have too, but they're more overlapping with gynecologic symptoms and pathology. And so because they go through the normal gynecologic evaluations, the OBGYNs look at them and all their testing is negative. They end up going to the GI doctor because it's a similar space. All that testing is negative. No one has been looking at the vasculature. There hasn't been a lot of interest in it in the academic community and in the private practice world. The focuses have not been on venography or taking photos. So what you have is this basically anatomic area, essentially the pelvis, which is poorly understood by medical doctors, is not of interest to academic doctors, but it's been there the whole time. And so we've actually uncovered a ton of pelvic congestion syndrome, completely unrelated to EDS or MCAS or POTS. And a lot of the women are having a lot of the same symptoms. And so I think what we have is a gap in our medical knowledge, and it's related around women's health, which is a common theme that we hear. And I'm really glad we found it because I think we're really changing lives.
Yeah, I'm actually married to a urologist, but I've definitely, when I was having some problems in my pelvis, it was like the black box. It seemed like so few people really understood and knew what things to look for. So, what kind of symptoms should primary care doctors or other clinicians, what kind of symptoms should draw their attention to? I know we're talking today in the interest of time, we could spend hours and hours talking about this, I'm sure. But we're going to talk about, May-Thurner, Nutcracker, malls, various different things. What kinds of symptoms should a person think, okay, maybe there is something going on in the pelvis, maybe in the abdomen, and this could be a compression syndrome, a venous problem, and then what kind of imaging should be done? And I understand that those are big questions.
Oh, yeah. So, what I like to do is medicine, as you know, can be very, very complicated. And a question like this, I'll start talking surgery jargon and I'll lose you in 3 seconds. But this is what I would tell the patients. And when we ask them, I would say 75% of the patients all have the same core of problems, and each has their own little unique characteristic to themselves. And those characteristics are where, when you listen to the online boards or you listen to, that's where they deviate. But the vast majority of the time, everyone has the exact same symptoms. And let me go down anatomically. If I was looking at you, because I'm looking at people like with x-ray vision, what would you complain of, right? So in the MALS patients, this is very rarely diagnosed. And I started picking onto this about 5 years ago when I had one very specific patient. And this is when it clicked for me last year when I correlated with that. MALS is the median arcuate ligament syndrome. It's very rare and has to do with the way the embryology is around the artery. There is a nerve plexus around it, and it creates pain. But the way the brain is innervated, the brain doesn't put a lot of onus into the abdominal organs on like a finger or a face or a nose. So it just has vague pain. MALS patients have a very specific pain in between their shoulder blades that bores through them. And it hurts, and it can come in and it can lead to ER visits. And here's the deal. You'd go to the ER, they find nothing, except if you are looking for it, you can get a certain cut or a side slice this way. So I'm looking at you this way, and you can see the angulation on CT scan. And if it's been there for a long time, you'll even see what we call a post-stenotic or post-narrowing dilation or ballooning around this, which is pathognomonic for it. What you do with it is an entirely different discussion. How you treat it is an entirely different discussion. But if you think you have it, you just need to go find a vascular lab that can do very specific breathing in ultrasound and breathing out ultrasound to reproduce it. So that's how we find MALS, but it's very rare.
Can I just ask, sorry to interrupt you, but I just wanted to ask, is it very rare even in EDS patients?
Yes, I have been paying attention to the EDS patients and some of the other connective tissue patients. Remember, the EDS group of people, they have a connective tissue problem. But MALS goes back to when you're being formed as an embryo, how your cells migrate. And that migration is very much a function of growth and is very individualized. So you could have twins with EDS and one have MALS and one does not. And this has to do with chemical signaling during embryology, which obviously you're going to be familiar with, but the audience may not. And so it is, I would say, a bad luck attribute if you have MALS. And I bet you there's many people who have it, where I think the EDS patients become more prevalent. If we were to look at why do you see so many, I think it goes back to the nerve issue. I think their nerves are more sensitive and they may be more attuned to the sensation, even though there are probably many people who have it.
Mm-hmm.
Right?
Okay.
So moving down, that's the MALS. So the next one would be the Nutcracker. Now, the Nutcracker I find very fascinating. I almost need a chalkboard to draw all the things, but I want everyone to kind of close their eyes for a minute and remember from your heart, because the next things all correlate together. From your heart, the blood goes into your kidney or it goes into your leg. And how does it get back? It gets back through the veins. 25% of our blood flow, and you can check it with your urology husband if I'm wrong, goes through our kidneys, which means your left kidney gets 12.5% of every heartbeat. This is a tremendous amount of blood. So it goes into the kidney, and if you look at the pictures, it comes back out of the kidney and goes back up to the heart. Now, take that. Everybody, except for very few people, are born with their superior mesenteric artery going over and the renal vein going under this configuration. That changes as you grow. So when you're young, there's a lot of space. And if you happen to grow very quickly, that angle can tighten. So we talk about the superior mesenteric artery angle. There's a vein under it. Well, if you're compressing the vein and a lot of blood is going through it, the body will find a way for it to come out. So how does it come out? It turns out that our left gonadal vein, which would go to the scrotum on a man on the left or the ovary of a woman on the left, happens to drain into that vein. And so many times we'll see that the valves, which are meant to drive the blood up or keep it going up into the left renal vein, will break. Or, this is even more fascinating, we identified this with Dr. Kinsella. with some of the POTS patients, they will develop a very large secondary collateral or network off that vein and bypass it right into the spine. And we've identified that many patients who have that pattern suffer from the headaches. And right now, I'd love to have a poll that you guys could show how many people said, oh, I have headaches, and I had a blood patch and it was negative. If we were to do the venogram on them, they would probably have this pattern, because the patients who do not have headaches traditionally have not had this drainage pattern. And the ones who do, do. So now you have the blood coming in, it wants to come out, and you have this compression. Well, around the superior mesenteric artery is another neural plexus. And what we've identified around this neural plexus, this is responsible for gallbladder, pancreas, and gastrointestinal symptoms. And what we've identified is in the population, the level of Nutcracker is very low. If you look at the literature for academics, it's very low in the population. In our cohort of patients who we've selected for and we're checking for because they're coming in with symptoms, 95% of them have compression of the renal vein. The prevalence in the office is far greater than what it's reported in the national population. Now, why do EDS patients have it? I think it has to do with the way that you're growing and the way that your connective tissue is. And why are EDS patients and maybe patients with pelvic congestion syndrome more symptomatic? Well, if you have an inability to bring your stretched vessels back together because you have a connective tissue disease, you're more prone to venous dilation, collaterals, or those side branches. And where do they go? They go around your stomach. You get early satiety. They start irritating the plexus around your superior mesenteric artery. You may have a pancreas attack, but your labs are normal. Or people out there will complain of, oh, I had gallbladder attacks, cholecystitis. They took my gallbladder out and my symptoms never went away. We treated a woman 2 weeks ago. Gallbladder was out, was frequently in the emergency room, lots of pancreatitis diagnosis in the ER. We did her stent. All the symptoms went away. The satiety, the bloating, these nerves from the superior mesenteric artery start traveling down onto the intestines, and they're telling the body, rest and relax or fight and flight. That's where the parasympathetic neuroganglion are. How they're being activated, I am unsure. But I think because the artery is squishing the vein, we must be activating something, because the stent seems to alleviate a lot of the symptoms. The left flank pain, the blood in the urine, the microscopic blood in the urine, the protein in the urine, these are all also signs of congestion, and the body starts trying to reduce it so you don't have kidney problems. A lot of those improve. So if you follow the blood down the gonadal vein, it goes right into the pelvis, into the adnexa. And we have venogram after venogram. On our Instagram page, we have a little anatomic picture that says, do you have Nutcracker or May-Thurner Syndrome? And if you swipe over, you can see a venogram of a patient who has all of these features. The blood goes in the kidney, goes down the gonadal vein, fills the pelvis, fills the spine. It was a really good example. So we see that why it works, I do not understand yet. And I think this is where research goes. But once we put the stent in, and I will preface, we can have a stent conversation a little bit later for the audience, because this seems to be a point of topic all the time. We do notice improvement in those gastrointestinal symptoms, upper epigastrum symptoms, left flank pain symptoms. As we start traveling down, the next big compression is that May-Thurner Syndrome, which is also very poorly understood by the medical community. If you ask your doctor what's May-Thurner Syndrome, most of them have never heard of it. And we're all born this way. We're also all born with our aorta, or our big red blood vessel off our heart, coming down the left side of our spine, and the big blue blood vessel, or the inferior vena cava, going up the right side of the spine. But we have legs, and so there's a natural crossing, right? And you can see where you're going to have a compression. Well, it turns out, unfortunately, that the soft vein, which is only meant to hold 1, 2, 3, 7 millimeters of mercury of pressure, which is very, very light, is being compressed by a blood vessel that has a heartbeat pressure, 120/80. What do you think wins? The artery wins. So you get a compressive syndrome. And it's interesting again, because when I've gone back and looked at CT scans, thousands of CT scans, most people, the way that the veins and the arteries and where they cross in relation to the pelvis, there's a drop off, like a cliff. And so even though the crossing has no physiologic effect. But in all of these patients, it's almost like everything is shifted up. And so we have a compression that is now causing symptoms. So now you have the blood in the left leg trying to get out because that compression is right in the upper pelvic brim. Now, every woman experiences during pregnancy because they have a large uterus sitting on this, right? And if you listen to the stories, often you'll hear that people got worse after their second or third pregnancy. So maybe they've compensated for a little bit, but they can't after time. So now I want you to take the two pieces we talked about, focusing on the Nutcracker and the May-Thurner, and we're going to put them together now as one giant picture. So now the blood comes down, it goes in the kidney, it tries to come out the kidney. It can't because it's hitting the compression. So it says, hey, I'm going to open up this gonadal vein. It goes down the gonadal vein. It goes into the ovary or the adnexa, the Batman-looking thing that you remembered from anatomy class. It drains into the internal system of the pelvis. It starts trying to go back up the iliac system, and it hits a second compression. So what does the pressure do? Blood finds a way. So it just goes across the pelvis through the adnexa. And the female pelvis has a tremendous amount of ability to develop collaterals. Again, I think because of the open potential space. And the people who have the connective tissue disease, I think, are far more susceptible to, again, this venous dilation. People without connective tissue disease may experience this during a short period of pregnancy, but once they deliver, everything goes back to normal and it's fine. But if you have EDS or any other connective tissue disease, or you've had multiple pregnancies or multiple insults, or you were born with higher grade compression than the rest of the population, right? This is persisting and it persists forever. So now what do you have? You have all these large, open, tortuous or bendy, ropey veins, and they have blood in them. And what is blood? Blood is water and proteins, and it's really heavy. And so what do you finally get? You start getting pressure, fullness, discomfort, right? Women will complain of painful intercourse, heavy menstrual periods. We have some women who have had multiple miscarriages, late term, let's say 12 weeks, 15 weeks, 20 weeks. They've had genetic analysis, no genetic abnormalities. So why? Well, if you have a high venous pressure, you lose what in medicine we call the perfusion pressure. So if your artery is one level and your vein is very close, there's only a small gap that the oxygen can travel through. You need a large gap. And if you have high pressure, maybe, and this is a theory, maybe that placenta isn't getting enough oxygen and the baby is actually starving from this. And so you wonder, because we see the pattern, is this starting to tie everything into a bow? Is there an actual reason why this is happening? It's very fascinating. And I wish I had so many more answers, but I don't.
Yeah, no, that's really, really helpful. And so many people struggle with a lot of the symptoms that you're describing. And of course, like you said, some of these are more pathognomonic and others are, quite common. But if you've ruled out a lot of the more common causes, it's really important for people to be able to hear this and hear, okay, these are the things that can cause that kind of a symptom picture. So if you have possible malls, then you would want an inspiration, expiration, ultrasound of the abdomen, is what it sounds like. What imaging studies are most important for people to get, and knowing that sometimes it's not so easy to get those ordered.
Sure. So the first thing is the least invasive test you can get, the least risk to you, and the least costly is an ultrasound. The limitation with the ultrasound, of course, is, and many people have seen these ultrasounds, is the technologist who does it. In our office, I had very experienced technologists, and we still took us 3 months to learn the right protocol to do it well. It's just not baked into the institutional knowledge, and people aren't spending time. Also, most places that have ultrasound techs, they're really looking for very protocolized things. So the celiac artery plexus, it's in the textbook. Most techs learned it in school, but a lot of hospitals don't offer it as an available study. And so in the ultrasound world, this is starting to fall into the not unknown, but to the rare and unique. And you might not be able to get one, but we can teach them. So, and there's always discussions. If there are people out there that said, "Hey, I have an ultrasound, they're not sure what to get," they could reach out to us and we could help guide them. But I would say you'd have to take the result with a grain of salt if you don't have an experienced team doing it.
Right.
CT scan. Many people have had CT scans for various ER visits. The CT angiogram, meaning they put the dye in your vein, is an excellent test for this if, and there's a big if, the hospital did the right protocol. Because what people don't understand is when you go through the the CT tube, the study is protocolized or told to do it in a certain way where, think of it like a slice of bread. Most of them are thick Texas toast bread. And what you need is like wafer thin bread. So when we talk about millimeters, and often an abdominal CT scan is 5 millimeters, which is what, like half an inch. What we're looking for is 0.7, millimeters or less than a millimeter. It's tremendously more packed in the data. And so when you're going through these areas, which the compression may only be 2 millimeters in size. And so a 5 millimeter scan may be skipping right over it or lacking what we would call the resolution. But it may be there. It's really hard to tell. But it's a really great test, especially if it has the front view and the side view and then the regular bread view, which a standard CT scan has. These would show both the renal compression, it would show the celiac compression. And if you know how to interpret it, it does show the May-Thurner if it goes low enough. But what I've identified is the May-Thurner, we find the best test for it is ultrasound and then an angiogram with an in the blood vessel ultrasound. That's how we diagnose everything before treatment. An actual ultrasound in your blood vessel.
I actually went and observed somebody, an interventional radiologist who's in my community, and they were doing that intravascular ultrasound, and I had never seen it before because I've been out of the OR for a few years. I don't know if I would have seen it if I was still in the OR or not, but anyway, it was really, really fascinating. So we have a lot of clinicians who listen to this podcast, and many who really want to help this population of people. So what about something like a venogram? Is that an appropriate thing to order? So it sounds like, I'm sorry, let me back up a second. So it sounds like they should order a CTA of the abdomen, but with thin cuts like the 0.7 millimeters?
Yes.
Okay.
So if you're ordering a CT scan, I would order a CT scan of your abdomen and your pelvis. I would ask for it to have both arterial phase and venous phase, which means they just run you through the machine with a slight delay because of the way the test goes in. And then you would ask them to make sure that you have thin slices. That's a CT scan. MRI, MRA can be a little bit tricky. MRI is really great for like the pelvic congestion syndrome to show those big dilated varicose veins. And then you can use that to infer that there's a problem elsewhere, right? If someone's having low pelvic pain, MRI is great. But CT scans and MRIs are really expensive, right? And sometimes getting access to them is hard, or you're exposed to radiation, or maybe you're pregnant or you think you're pregnant, right? These are no-nos. So ultrasound is a great test. For ultrasound, we rarely do the celiac, but if you do the celiac, you say, hey, I need to look for median arcuate ligament syndrome. I need inspiration velocities and expiration velocities, because as you breathe, your diaphragm goes up and down and pulls tighter on those bands or releases them. And you can demonstrate a change in velocity objectively, very scientifically. So that's a great test. The Nutcracker we've been working on, we've noticed that there's a lot of people who have it. You can see it if you're not eating, you have a thin body habitus, you have a good tech. But even my technologists sometimes have trouble seeing it. But we check it and we use that as a rule in, rule out test for the venogram. Because if it looks like everything is open, well, then you don't have it. But if you're having symptoms and it looks like you have what we call flatline or monophasic waveforms on the left with dilation, you're able to measure the vein. And then you see on the compression, it's very small. You can infer there must be some compressive process going on, even though you don't know all of it. It makes one feel more comfortable to go to the next level. The ultrasound is, we find, useful again for screening.
And that's exactly what I was hoping that you would do, and you did that in a stepwise fashion because, right, you don't send somebody right away for the more invasive test if you're not sure if you're actually in the right ballpark or not. So thank you. That's very important.
Yeah, we believe in education and empowerment. I mean, by the time many people hit our office, they've seen 12, 13 doctors. They've had every blood test. They've had endoscopy, colonoscopy. They've had intravaginal ultrasounds. They've had CT scans galore, and everything is negative. So you sit and you talk, you keep an open mind, you do an ultrasound, and I would say 99% of the time, the people who walk in the door and you do the ultrasound screen positive. And if they screen positive, we will then feel more comfortable doing a diagnostic venogram. And we never treat at the first visit. The beauty of a nice private practice is we have great flexibility, great availability, right? The insurance companies are a little bit difficult to deal with, but usually we can get people in within a week from the time of diagnosis to the OR, and we diagnose everything with intravascular ultrasound because a straight venogram, actually, I must have missed a ton of it. I used to do the venogram, and again, remember we talked about compensation? The body finds a way to compensate. So it elongates the iliac vein, it pancakes itself out so it's able to try to carry the blood flow. But not unless you look for it, we actually find it, and it's been sitting there the whole time.
Okay. We're going to take a quick break. And when we come back, we are going to talk about how you address these problems, what the kind of therapeutic options are. And so we're going to take a quick break and we'll be right back. As someone with EDS and who treats patients and does lots and lots of these podcasts, I am always looking for products that are going to help me be more comfortable. I want to tell you about Cozy Earth. There is nothing more comfortable than getting into a cozy bed and making being at home the very best part of your day. Cozy Earth is so confident in their products that they actually offer a 100-night sleep trial. This is insane. If you don't love their sheets, after a whole 100 nights, you can actually return them hassle-free. And they also offer a 10-year warranty. That's insane. A whole decade. So start the new year off right and give your home the luxury it deserves. Make your home the best part of life. Head to CozyEarth.com and use my code BENDY for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here on the Bendy Bodies podcast. Give the gift of comfort that lasts beyond the holidays and carries into a cozy new year. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we are back with Dr. Hacker, and we're going to be talking more about treatment options. And I think we're going to take a little quick diversion into POTS patients and pelvic venous congestion. You shared with me during the break that you had a theory about POTS and pelvic venous congestion. If you could share that with me.
Sure, absolutely. So one of the things we've observed, and it actually links very closely into our theory about MCAS, Doctor, I don't know if you ever had a chance to work at a trauma center. Did you?
In training, level 1 at Mayo, but, post that, level 2, level 3, as the anesthesiologist. So.
Yeah, but this is very powerful because you can maybe correlate what we've been talking about, and I'll blend it all together. So, as a surgeon, we trained very heavily for trauma, stabbings, gunshot wounds. I trained in New York. I was in Philadelphia. I was in Pittsburgh, right? I've dealt with my share of messes. But one of the things we've noticed is that when someone loses blood very quickly or they're in an acute situation, they go into shock and their body behaves in a very specific fashion, right? Their blood pressure behaves in a certain way and their heart rate behaves in a certain way. And what is that way? Well, if you have no blood going to your heart, the speed goes up and your blood pressure goes down. Now, in the POTS patients, they are able usually to maintain their blood pressure eventually, but you usually see a small drop. If you have pelvic congestion syndrome, as we talked about earlier before the break, you have these large dilated veins. Depending on how much volume you have, because these veins are what we call in parallel, meaning they're all next to each other. There's a tremendous, what I would call, or we would call, potential space. And as we know from probably talking to your other guests, a large majority of our blood is actually stored in our legs. The legs we can deal with. So if you have a compressive syndrome that's preventing some of your venous blood to quickly mobilize when you change positions from a sitting or a lying position to a standing position, if that's flowed, right, your heart's beating and all of a sudden it's beating dry, figuratively, right? Every time it beats, it's kind of not pulling as much blood as it should. If you compound that on with a potential space in the pelvis where there are no valves, where the blood can kind of slosh figuratively wherever it wants, you're adding more blood from the heart. So if you can just guess, and it would take a really eloquent study to do this, someone stands up, not only now can they not mobilize the blood out of their left leg or right leg, because some people have both legs compressed by the aorta, and then it's being held in the pelvis, all of a sudden you are, quote, losing 250 milliliters, 500 milliliters, until you're able to move and catch up, which can take a minute, 2 minutes. And so your heart is just beating away. You're behaving like a trauma patient. Now, how many of you out there get anxiety, feel like blood pressure, shocky, nervous? You see this all the time in this community at a very high preponderance, more so than in the normal population. So one of the hypotheses is, are you actually hypovolemic from these compressive syndromes, from these pelvic dilated syndromes? And is it leading to a shock state? And what is a shock state? It's your body going crazy, your sympathetic system being upregulated in a what we call compensatory mechanism. And I'm so sorry, it's the only way I know to say it is real doctory. But your body is trying to survive. And what happens when you lie down and you raise your legs? Well, you're able to compensate for that. You're taking that stress away. And what do the patients all do? They all lie down, raise their legs, they transfuse themselves, right? And they usually feel better and the headaches go away, right? Well, what else can a shock state do? So now we have the pelvis, let me go back. So it's holding all this blood. So we found some of the patients who we've treated for the pelvic congestion syndrome and we've placed the stents into, a few of them have completely resolved their symptoms, but most of them say their symptoms have improved. Because I think there's more to the pathology than just the blood flow, right? I think there's a nerve component to this. And so we're always very clear that we don't expect it all to go away. We just expect you to go from a 10 to a 5. And most people will say, I would love to be a 5, right? But MCAS, right? We all have heard about MCAS, right? Well, Dr. Cutchins and I were having a discussion at the dysautonomia clinic. And yeah, there's beautiful studies that say that the mast cells, the cells that release all this histamine and these byproducts, they're built a little bit differently. But my argument is, okay, you have connective tissue disease and your cells are fragile little balloons. You still got to throw the balloon for it to pop. So what does that throw? I think the constant trauma and stress of the hypovolemia, sympathetic, parasympathetic system, right? The parasympathetics are being stimulated by the compression. And why do I think that? Because I know from doing aneurysm surgery, the sympathetic system is on the right side of the aorta, specifically over the right iliac artery. I've seen it. I have to be very careful about it when I do surgery. The parasympathetics are coming down from the stomach. They're going around that celiac artery. They're going around that superior mesenteric artery. They're being compressed. The heart's beating. They're going around the left side of the body into the leg. And I think just like acupuncture, they're being overstimulated. And that overstimulation is leading to the brain fog. Because you're not having pain, you're just having overstimulation and your body doesn't know what to do with it. So you're not thinking straight. So alleviating the compressive syndromes is like alleviating all of this like cerebral noise. Then you're adding the shock-like state of the standing and the sitting and the standing and the sitting. And what does your body do? It basically becomes fragile. Every time you stand up, it's like you're getting shot in the abdomen. You're losing a whole bunch of blood and your body has to compensate. And you do this over and over again. Everything is on edge. And I think that's even where the mast cell diagnosis comes in. Because if you notice, most of the patients, and I'm very curious in your population, if you did a survey, you say that people don't show up and say, hey, I have mast cell. Oh, and then I have POTS or EDS. It's always, I had these symptoms. And then eventually I've also noticed I've developed an allergy.
Yeah, I would say that's definitely very, very, very common that I'm asking them. A lot of people have, of course, listened to the podcast. They know about mast cell, and so they kind of say, "I really suspect that I have it," or in some cases, they've been diagnosed or a family member's been diagnosed. But you're right, a lot of people have either diagnosed or suspected EDS or another connective tissue disorder, and it kind of starts there. I'm curious to ask, when you say that you have 95+% representation of females versus males, but you're also describing like the pelvic venous congestion, I'm thinking about, males with POTS, which we know there's fewer males than females with a lot of these conditions. But are you seeing much in the way of males with pelvic venous congestion and POTS, or why do you think there's such a massive difference there in your practice?
So literally, I think we have 6 gentlemen who have the diagnosis of POTS. Several of them we've treated, and we've done the venograms on them on 2 separate occasions, one during treatment and one during the diagnostic phase. And the pelvis is just, in a man, is just so much tighter. Um, there's much more distinction between the left side and the right side. You don't see the same cross pelvic. You see there's a couple potential veins around the pelvic brim. What you will see is the gonadal vein reflux, but usually you can diagnose that they have it just from doing a physical exam, and they have what they call a varicocele or varicose veins on their scrotum. You have to remember the scrotum and the labia are exactly the same organism in men and women, embryologically, except men is on the outside, and so we see it, and so it gets treated. And women, that ovarian vein gets seen, it doesn't get identified. So I think in men you have a much tighter pelvis, and just female anatomy of a bigger pelvis. You have this really a potential space, right, to hold a uterus and a baby. And I think just from the way that we have developed, there's much more cross flow, and you really see that flow around the. It's very hard to describe to the group, but if you were to look at someone from the inside, like peek over inside the bowl, if you will, opening from the belly button, there's a big space around the vagina, around the inside where the organs are, huge amount of veins around the outside of the uterus, and a ton of veins around the ovaries, and they just cross. I mean, if you looked at, again, the referred angiogram that I showed you, it is so representative of what we see so many times. And you can just see where all this blood goes. And in the men, you don't see it. Usually they have the iliac vein compression, but yet they have the same symptoms many of the time that they're feeling. And that's why I say, okay, there must be more than just the anatomy we're identifying. That's why I keep going back to nerves. And that's why I think one day, if we have the community talks, we'll say, maybe POTS isn't the best answer. Maybe we just say you have dysautonomia. You have a dysfunctional autonomic system for various reasons. So a little bit more general, a little bit more broad, but more inclusive, if you will, and less specific.
Okay. And so I know this is going to be hard because we've talked about multiple different conditions in this conversation so far. But in terms of treatment options, how are you approaching this? You talked about stents already. So can you run us through kind of like so now you've identified the problem. You've identified that there's either MALS or pelvic venous congestion or Nutcracker or May-Thurner, which I understand are all different things. But what would we be looking at in terms of treatment? And I guess actually that is another question that I have is, why do some people have more than one of these problems too?
Let's go with the last question. Why do they have more problems? There must be a developmental component. Meaning, my best hypothesis is that um, when the kidneys are formed, they start low in the pelvis and they rise up. And so we see many different patterns of kidneys. Some people have one renal artery, some have two. Um, and the venous system is kind of growing at the same time. And it's very complicated the way that blood vessels form. But what do you have? You have 2 shifting systems, an arterial system and a venous system. There must be something in these patients where they're not aligning like the rest of the population. And it's almost as though the venous system is being crammed into the arterial system. Like everything is too high. Don't ask me why, but that's the pattern we observe. Or because we'll notice a loss of fat on the renal veins. Most of them all have a loss of fat right here at the corner where we see the vein run by. They all have it. And when we do normies, they have a nice fat pocket right around it. And I think this is something that would just have to be researched and followed and studied. So why? I don't know, but there must be some kind of connection to all of this because it's too common for it to be coincidental, right? As far as treatments, treatments are a very interesting question because we kind of aren't fixing the problem. Some people say their problems go away. We're just trying to reduce the symptomatology because we've noticed a consistent pattern, right? So what are we trying to do? Well, if we're doing with the malls, you're trying to take away the band and you're trying to free up that artery. But the most important part, and if you read the papers from the group in Seattle, they're trying to take the nerves and strip the nerves off the artery. It's more than just plucking a string. You have to what they call de-innervate the artery so that the pain goes away. The problem is that's a surgical procedure and you can develop scar tissue and it can come back. So there's no guarantees, right? Or you have to learn how to deal with your symptoms, which is a terrible thing, but we've all heard it. But sometimes just knowing what you have and knowing that you're not broken, you're just a little bit different is empowering, right? How to get through an attack. For the Nutcracker, this is highly controversial, and I'll lead with that. The traditional, if you go to the large academic centers here in St. Louis, there's a very large academic center. The threshold for repair is tremendously high, and it's because the surgery was very complicated. So what was the threshold? You had to be urinating blood because the back pressure was so high. You had to be going into kidney failure. You had to have exquisitely bad flank pain, or you had to have some kind of organ threatening issue. Why? Because they offered you what we call a left renal vein transposition, where we cut you open, move your guts, cut the vein, put it somewhere else, and sew it back on. The 1-year patency, or how long the opening stays open without any assistance, is only 80% at 1 year from that operation. The other option was they cut you open, they spread your guts, and then they take your kidney out, and then they put it somewhere else called an auto kidney transplant. You can imagine these are tremendously large operations. So the threshold to treat has been, I think, appropriately very high. Technology improves, people start doing stents. They start doing stents. Well, me saying stents is like me saying there's soda. How many versions are there out there? There's a tremendous amount of versions out there. And I think one of the problem is people say, hey, I had a stent, but it's so not specific, it leads the wrong thing. So I'll tell you, there was large studies performed at major institutions that you trained at, and they had terrible outcomes. Well, why'd they have terrible outcomes? I think it was for 2 reasons. One, the technology was put on delivery devices that look like harpoons, literally look like harpoons. And they weren't made to make these sharp turns, and they were done with fellows. So you had bad technology and poor training. The training is excellent. You had people where an attending wasn't doing it 100% of the time. So what did you have? You saw a high level of perforation or puncturing through the vein and failure. And the third thing is they used what we call open cell stents, or a mesh work that you could see through. And in the venous system, we know from doing other types of surgery, the body starts developing scar tissue and it grows right through that, and you get an occlusion. What do we do differently? Well, it's 2020, almost 2026. We use a stent by Gore. It's covered in an inert material called Gore-Tex, and it has nitinol in it, and it's covered. And I use a very large stent, the biggest one they make, and we've really perfected the technique. The wire we use, the delivery sheath or straw that we use to get it there, the stent itself is oversized to the vein so that it gets pinned by the compression and opens everything up. So we have both a mechanical fixation and a length component. It's still a very risky procedure. They still can move, but it's far less. We've had 0 perforations. We've had 1 migration. And I would consider it to be very safe and very good results. And because it's covered, the body doesn't grow through it. But how you do it and who does it really does matter. And in the iliac vein, the May-Thurner Syndrome is a very well-known pathology. It's a very commonly treated pathology, but what we do in our lab is very different from everybody else in the way that we deploy it, the stent we've selected, the why we've selected it, and the sizes that we use, because the complication there is pain and again migration. And we've only seen one migrate, we've had no perforations and no thrombosis. So it's complicated.
Definitely. What about mast cell type reactions to the stent?
So it's fascinating. We've spoken to several dermatologists and immunologists. The stents and most medical hardware is made out of a metal called nitinol. So it's titanium and nickel. It was produced by the Navy to prevent things like the Titanic from occurring. And nitinol is great because you can give it a memory and then shrink it down so it can deploy it. And when it gets hot, it expands to its memory size. And you say, oh, I have a nickel allergy. Well, it's been brought up that the nickel in your watch, the nickel in your earrings, the nickel in your, right, is touching your skin. And the immunologic cells in your skin and the content of nickel in those metals is very high, and they're different. The intravascular system is unknown, and we are unaware of anybody who's had a reaction to nitinol stents. They're commonly deployed in the country, and it's not often reported that people have a problem with them. We are cognizant of it. We've had discussions with colleagues in the community about this. We've even gone so far as to suggest maybe you should patch test. But again, you're only patch testing or taking that stent and taping it to your skin, and that's not your blood vessel system. And the immune system on your skin is going to be different, we hypothesize, than the immune response within your vascular system. Caution should be, of course, given.
And what are outcomes like? And again, I know we're talking about multiple different problems here, but in terms of like short-term and long-term outcomes for the stenting and procedures that you were just discussing.
Sure. So I think outcomes can be kind of graded on several things. The first thing we've identified is that these can be painful, really painful. And that's one of the things we identified early on as we were following the traditional surgical literature of whatever your vessel size is, make the stent 20% bigger. Why? It allows for what we call radial force or more external squeeze. In these patients, the compression is so significant. I mean, we're talking from 16 millimeters down to 4 or 5. And there's likely scar tissue with the nerves and the arteries, and there's a big muscle behind it. That when we were doing that, we had people in excruciating pain. Now, we've never had to have one explanted, but people have had their stents at other institutions removed because of this. So we started using the intravascular ultrasound to give us and guide us more accurately the size of the vessel. And we've been sizing more what we call 1-to-1 to try to match what the blood vessel is before the narrowing and what it is after. And it's usually a little bit smaller after, to try to reduce the amount of pain and discomfort. So from an outcome standpoint, when people get both the renal stent and their iliac vein stent for May-Thurner, they'll have pain between 3 days and 2 weeks. We've been found a really good cocktail with cyclobenzaprine as a muscle relaxer at night, coupled with a high dose non-steroidal anti-inflammatory for a few days to quiet the system down. These are very physiologic drugs, and then we taper them off. So even people who have MCAS or have history of like gastric lining issues, they can tolerate this for a few days. And I only had one patient who, for a very long period, had pain, and it was because we did a very aggressive treatment, oversized. From a symptom standpoint, this is the $10 million question that everyone's been waiting for. We do surveys before and we do surveys after. And the research paper that we presented at the Dysautonomia 2025 was what was the statistical analysis of this. And it was a p-value, meaning when they run it through the computer, they say, is this by chance or is this actually real? The p-value was 0.0001. And the statistically significant value would be like 0.05. So it didn't get any smaller. So we've noticed that when you examine people, they score on their testing, which we use the Malmo-Potts score, which is a qualified test, I think from the Netherlands, if I recall correctly. Do not quote me on that, but it's not from America. The Malmo-Potts score, they score statistically significantly better after versus before. Some people, we've gotten letters, my partner has received letters, like letters saying, you've changed my life. We've seen people get off disability, go back to getting jobs. We've seen tremendous improvement in life. Nobody that I'm aware of has said, I feel worse. And there's a group of people say, I really don't notice anything different, but when you dig down, they'll say, okay, I have fewer symptoms. But we're very transparent. A lot of people, they'll still get the POTS-like symptoms. They'll still get the dizziness, right? Some of them are still going to have the MCAS allergies. But I think the severities are decreasing. I'd really be interested to see that after a period of 1, 2, 3, 4, 5 years of being treated and still having good medical management, right? With the right meds, with the good POTS doctors, do we actually see their bodies maybe start recovering back to normal? And I think that's the big question.
And what do you think are the biggest misconceptions amongst clinicians or patients when it comes to these problems?
I think the hardest thing is that this is unknown, right? So doctors want data. So the tests are all negative until we've been able to finally do these venograms, right? And there's no education on it. And so let's face it, if you can't see it and you can't touch it, it doesn't exist. That's just how medicine works, right? And so people are coming to these clinics complaining of vague abdominal pain, testing negative. Going to OBGYNs complaining of pain, testing negative. Go to the cardiologist with these real symptoms, testing negative. Or they have POTS, but it shouldn't be that bad, right? And yet they're we're just always falling short. We're always falling short. And so I think it's just a lack of education, because I think this is exciting. It's like something new. We thought medicine was known, right? Except for a lot of neurology. And I think we're kind of on something that's just been missed. It's been there the whole time. But with angiography, access to less expensive tools for diagnosis, private practices like myself are able to go out and do these things because hospitals are not equipped to do this. We're actually able to prove it and demonstrate it time after time after time.
And people listening to this podcast are from all over the world. We have many, many different countries of listeners, which is amazing. And of course, all over the US as well. If somebody is thinking that this is a potential problem for them, one of these conditions that we talked about, Malls, May-Thurner, Nutcracker, pelvic venous disease, etc., what kind of things should they be looking for in a clinic that they might be considering going to, or a clinician that they might be looking at?
So I think the first and foremost thing is, if you think you have it, trust your gut. You know your body more than anybody else. I think that's the most important thing. And most of the patients have been advocating for themselves. I think the second thing is, it's our job as clinicians to be able to relate to patients. But I think in this particular case, the patients have to basically relate to the doctors. So what do I mean by that? You just can't come in with a stack of papers and say, I've had all these surgeries and this is how I feel. I think if you had a journal or you had a story and you were able to show the doctor, right? This is what I do and I get these symptoms. But when I do this, I don't give that. You can help take someone who is willing to listen, because that's probably the next most important thing, is a clinician who's willing to listen and explore this diagnosis with you, right? Help guide the clinician on what it could be and what it couldn't be, by breaking it up into little palatable pieces, which I've been trying to do this whole time, right? So I break it up into, do you have upper GI symptoms? Do you have upper, gallbladder, pancreas symptoms? Where's your pain? When do you get it? And if you are looking for someone and you kind of journal this stuff, I think you'll have a much more friendly journey. And I think the doctors will be much more open to, I think we have a real problem here, versus the typical dismissal that many people have.
Mm-hmm, mm-hmm.
How do you find those doctors? I think that's also the $1 million question. I would advocate that the people who are involved in this community, which we've been trying to join, working together and developing a network to help patients. I will tell you right now, if any doctor or patient were to reach out to us, it would be our pleasure to help provide protocols, talk to patients, talk to doctors on their behalf, even though they're not my patient. Maybe we can help guide you in your local area if you can't make it and join us.
That's an incredible offer. And I know that you are trained as a vascular surgeon. Of course, you did general surgery first, and then you did vascular surgery. There are also interventional radiologists who are doing some of these procedures, correct? So can you
Absolutely.
kind of explain? Yeah, can you kind of explain? Because I think that there's areas in medicine where there's some overlap. Like there's interventional pain procedures that might be done by an anesthesiologist or a physical medicine and rehabilitation doctor or an interventional radiologist. So this might be another one of those cases, but I think it might be really helpful as we're getting close to wrapping up here for people to just know a little bit about what that difference is, to just kind of get a little better lay of the land.
Yeah, absolutely. I think there's a lot of just fantastic physicians in our country and around the world. Not everyone took the exact same path to train, and everyone sometimes ended up in the same room with different backgrounds. Uh, a vascular surgeon and a general surgeon, right? I left medical school. I did 5 years of training, opening abdomens, learning intra-abdominal pathology, taking care of patients in the ICU. I became a vascular surgeon, operating on blood vessels, opening them up, looking at them, studying them, bypassing them, as well as doing catheter based procedures with IV dye and x ray. The radiologists end up going to school and they train on the interventional side, but they, short of maybe a residency experience for a year, didn't spend a lot of time in the abdomen. And so the wire skills, the interpretation of the images, they can be wicked. And I think the cardiologists who are involved in the space all do the same thing. But there is a difference when one looks at a problem. I don't look at the X-ray the same way that a radiologist does, and I don't look at the heart and the POTS data the same way that a cardiologist does. And so everyone has something very valuable to bring at the table, and there's an area where we all overlap. And there's areas where we're weak or we miss stuff. And so I think it's just learning, who do you have access to? What are their qualifications? Does this person sound like they know what they're talking about, or are they just trying to do something, right? Or is there something to be learned? We realized from all of this, a lot of women were just getting their ovarian veins coiled because of the pelvic congestion syndrome. And if you talk to them, and again, I'd love to know in your comments section, you let me know later, if anyone's had only their left ovarian vein coiled and their symptoms got worse, we've identified that's because they actually had a nutcracker. The ovarian vein was a compensatory mechanism, and you just
Hmm.
shut that down. And I
Hmm.
have several patients who are like that. And we did the stenting and they got better because we
Hmm.
gave them that natural flow. And it's just something that was missed in the community because everyone's been looking at one little part, the May-Thurner part, the Mal's part, the
Hmm.
Nutcracker part, the
Hmm.
gonadal vein. But if you take a step back, they're actually all linked together. And so that's where we came up with our diagnosis. Even how we treat it, we do it in a very, very specific order to try to do as little as possible. So we always do the diagnostics, have a discussion. Then we'll treat the iliac vein compression, try to improve drainage out of the leg, out of the pelvis, out of the ovaries. And if they're still having, then we'll do the embolization to try to close that up and isolate the left side from the right side. And then if they're still having problems, only then do we do the renal stuff, taking out the gonadal vein and doing the stent simultaneously. So we do it very stepwise, very algorithmically, and very thoughtfully because every person is different. Some people, we never have to do anything more than the iliac vein stent. That's all they need. Those are all my secrets.
Yeah, good. That's what I was hoping. I was hoping to get all your secrets. Speaking of secrets, and I think it's funny because your last name is Dr. Hacker, and I think as a surgeon, you probably get teased about that all the time. I would think. And we're going to ask you for a hypermobility hack. Speaking of which, so what do you have in the way of a hack for us? Speaking of giving us all your secrets.
So I was thinking about this, but I've got a good one. So I hope it's a good one. Again, let me know if I'm right. So what's the biggest thing that a lot of hypermobility people, POTS people have, right? They get up and they feel really dizzy and they feel terrible. right? So let's have everyone try this for a month and see if it works. If you're going to get up and you normally stand up and you start feeling lightheaded and you start feeling terrible, don't do that. What I want you to do is start standing up, jump on your feet for about 3 to 4 seconds, sit back down, wiggle your legs. Okay, what is that going to do? That's crazy. What it's going to do is it's going to start telling your body to tighten up your arterial system. If you do have normal veins, they'll shrink down a little bit. You'll move the blood out of your legs and you'll start to basically recruit blood for that engine of your heart so that you're not running dry when you stand up. So if you stand up, you tell your body, I'm going to get up, and you sit back down, you're no longer at risk for a tip, a fall, a hit, right? You're prepping your system. Do that for a couple more seconds. Maybe stand up one more time for a couple seconds, sit back down, give yourself. So maybe it's a 15, 20-second thing. Stand up and walk. And I'd be very curious to see if you do better, because I think from our experience, patients say that this really does help them.
Okay, I love that. I often tell people to, move their legs, squeeze their gluteal muscles, etc., but not stand up, jump, and then sit back down. So I really like that. I can't wait to hear from people, because if you're listening right now, well, of course you're listening right now. Lots of people are listening right now. And please, let us know what you think of this hack and how helpful you thought this was, because I think that's great. I love getting new hacks for people to try. So before we go, I would love to hear where we can learn more about you and your practice. And also, a question that I get asked all the time is, does this doctor take insurance or not? And also, we know that medical licenses are state dependent. So some doctors will see people only from their home state. Other people, if they have to travel to you for any kind of intervention, you can't do that by telemedicine. But could you explain a little bit about how your practice works and if there's any state limitations, et cetera?
Sure. So we're in Missouri. We're in St. Louis. We're about 20 minutes from the airport in the west. Our practice is called the St. Louis Vascular Surgical Specialist, and we're the only private vascular surgery practice in the entire St. for like 300 miles. Insurance, we take almost all the insurances, and we take cash, and we have special cash rates. There is not a lot of places to get diagnosed for POTS disease. We're just now going through a protocol, shoring it up with some of the colleagues in the community to make sure that it would pass muster. And we're going to start doing some POTS testing for patients so they don't have to be waiting for a long time. As you stated, state licenses are really crazy. So right now, I only hold a Missouri state license, but I've been licensed in California and New York and Pennsylvania and Ohio for the years. I have been contemplating expanding those again if there was a need or a resource, in developing satellite clinics across the country where maybe we come in for a few days and we'll have a big clinic and we'll work with existing physicians who have large patient populations, but would like to get them treated locally. So if there's any physicians out there who said, hey, I have a clinic and we would love you to come out, we would love to explore any way that we can share the expertise with the community across the state. To reach us, you could email us at info@stlvascular.com, or the website is stlvascular.com. And there's not a lot of hackers out there, so it's easy to find. Google. I mean, with a name like hacker, you can't be bad, or you'd be broke. So,
right, yeah, definitely. So, if somebody is from a state besides Missouri, so long as they're coming to see you, you will see people from other states. I just want to make sure that people are really super clear about that.
Absolutely. Absolutely. Okay. So we've had people come from Canada. We've had people come from Tennessee, Arkansas, Colorado, Illinois, California.
Great.
All over the place. As long as we're in our state, we can do it.
Perfect. And what about when you said that you're working on POTS testing? Are you talking about that you're going to be getting a tilt table, or?
We own a tilt table. We just want to make sure we're doing the right
protocols.
Okay. Apparently, there's not a lot of facilities out there that have them. So
it can be really hard to get tilt table tests and full autonomic lab testing can be very, very challenging. So I used to send people to an autonomic lab and they would be on a wait list forever. And then they would often get canceled the day beforehand. So I can't do the full, autonomic test that they would often do in those labs, but I will do stand up or, the quote Nassau lean test. I'll do orthostatic vital signs for 10 full minutes after they stand up. Have them lay down for 10 minutes first and then stand up and do it for another 10 minutes. And I will diagnose POTS based on that if it's positive. So, okay. Well, this was such a great conversation. And I know that people will be learning so much from this, both patients and clinicians. There's a really vast audience that we have. So thank you so much for taking the time to chat with me today. I know your schedule is very, very busy, but I really appreciate it. Well, I am so grateful to Dr. Hacker for coming on the Bendy Bodies podcast today and teaching us so much about compression syndromes and stents and these complicated conditions that are so often missed. I'm sure you found this super helpful, and hopefully you're going to have more hope for future and alleviating some of your symptoms. Thank you so much for listening to this week's episode of the Bendy Bodies podcast with the Hypermobility MD. Check out my other resources, including my newsletter, The Bendy Bulletin. Visit my website at hypermobilitymd.substack.com. Help us spread the word about connective tissue disorders by leaving a review and sharing the podcast. This really helps more people find the show. Did you know that I also offer one-on-one support for both clients and healthcare professionals? Whether you're living with a connective tissue disorder or caring for someone who is, I've got your back. Check out my coaching and mentorship options on the services page at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, or LinkedIn at hypermobilitymd. You can find Human Content, my amazing producing team, at Human Content Pods on TikTok and Instagram. You can find full video episodes up every week on YouTube at Bendy Bodies Podcast. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements shared on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider for your own care. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.